Welcome to our video on encephalitis. Let's get started. We'll discuss the definition, clinical features, as well as the diagnosis and some highlighted cases, and then the management of encephalitis. So encephalitis is defined as inflammation of the brain parenchyma, and it's usually of viral etiology, for example, herpes simplex virus and West Nile virus. So when we discuss meningitis, that can be caused by all types of pathogens, such as bacteria or even fungi. But when you think encephalitis, just think mainly of viruses. Now, a patient with encephalitis usually presents with fever, headache, and nausea. Now, altered mental status, such as confusion and agitation, is also typically present. And since you're dealing with the brain and that inflammation, it makes sense that you could also see some neurologic deficits. These may include hemiparesis, focal cranial nerve deficits, aphasia, or even hyperreflexia. And once again, dealing with the brain, it makes sense that seizures could also occur. Okay, so now let's discuss how you diagnose encephalitis. So a CT scan is the initial step to exclude any space-occupying lesion prior to performing a lumbar puncture. And this comes to that idea of brain herniation. You don't want to perform a lumbar puncture and increase that pressure in the CSF to then exert on the brain, causing a herniation. So you just want to make sure there's no contraindications to a lumbar puncture. And if that's okay, and you get the okay from looking at the CT scan, then you can perform it and then you do a CSF analysis. Now, if you've already seen our video on meningitis, then you'll know that viral meningitis has a certain CSF analysis. And it's actually the same findings as you'd get in viral encephalitis. So for example, there's going to be an elevated white blood cell count in the CSF, and it's going to be predominantly lymphocytic. Now, an MRI is more sensitive than a CT scan. So when you get that, it can actually help you identify what exact pathogen is causing the encephalitis. Not always, but it can. Also, an electroencephalography, or EEG, can be helpful in the diagnosis. So for example, a focality that really indicates the temporal lobes are inflamed or infected with the virus, then that should make you think of HSV. So when it comes to thinking about an MRI being useful in identifying the pathogen, really the only pathogen you keep in mind here is HSV. So temporal lobes, HSV encephalitis. Now, CSF PCR is important because it can also be helpful in confirming the pathogen. And it's actually commonly performed for HSV and enteroviruses. Now, serologic testing may also be helpful. For example, it can detect IgM antibodies against the West Nile virus. You'd see that in the CSF. So in other words, in diagnosing encephalitis, you make sure that it's okay to do a lumbar puncture, you do it, and then the results will indicate a viral encephalitis. And then you can try to identify the pathogen via PCR or MRI, specifically if you're thinking about HSV. And then you can do serology, which can help you identify antibodies against the virus. Now let's go through some specific highlighted cases of encephalitis. So let's begin with HSV encephalitis. So this virus is the first pathogen you want to exclude in any case of encephalitis. And in these instances, it's typically acute, and there's often behavioral syndromes that are present. For example, Kluver-Bucy syndrome and hypomania. You may recall from your preclinical studies that Kluver-Bucy syndrome is characterized by hyperphagia and hypersexuality, often described as hyperorality. And on CSF analysis, you'll see an elevated red blood cell count. And on MRI, as we mentioned before, there will be abnormal signaling in the temporal lobes, and that's very characteristic of HSV. However, the gold standard is a CSF PCR. So here's an MRI of a patient diagnosed with HSV encephalitis. Note the temporal lobe involvement. Let's next discuss Toxoplasma encephalitis. This results from reactivation of Toxoplasma gondii from a prior infection. And it's the most common manifestation of toxoplasmosis. In other words, there's a lot of things that toxoplasma can cause, but if you're thinking about its reactivation, think about primarily encephalitis. So this typically affects HIV patients when their CD4 counts get below 100. And on MRI, you'll see multiple ring-enhancing lesions. And on serologic testing, there'll be positive Toxoplasma gondii IgG antibodies. Let's move on to the management of encephalitis. So empiric therapy of intravenous acyclovir should be administered while waiting the results of confirmatory tests. So in other words, you think your patient's got a viral encephalitis, or you just think that they have encephalitis, so viruses go to the top of your list. So before you even know the pathogen, give IV acyclovir. And you really don't want to delay that because HSV in particular is associated with a very high mortality rate. Now, supportive therapies such as analgesics and anticonvulsants is usually required in other cases of viral encephalitis. Now, in the case of toxoplasma encephalitis, you'll notice that's not a virus. So it's not always a virus. So in this case, would acyclovir be helpful? No. So you're going to want to give sulfadiazine and pyrimethamine, and you can also add leucovorin. Now let's do a question to apply what you've learned. A patient is brought into the hospital shortly following a seizure. The patient is very confused and has a headache, fever, and nausea. The patient's spouse notes that recently the patient has been eating more than usual and is easily aroused. MRI reveals bitemporal hyperintensities. What are the best next steps in the management of this patient? Feel free to pause the video as you consider the answer to this question. Okay, so this patient presents following a seizure and is experiencing symptoms of headache, fever, and nausea, which are all fairly nonspecific. Additionally, though, the patient has shown signs of Kluver-Bucy syndrome, so that hyperphagia, the patient's eating more than usual, and that hypersexuality, they're easily aroused. So based on these symptoms alone, you should be highly suspicious of HSV encephalitis. And this suspicion is actually supported by the bitemporal hyperintensities seen on the MRI. And the patient's CSF should be obtained at this point, if you haven't already. And you need to do that to diagnose using the CSF PCR. So you want to get that lumbar puncture and you want to get a PCR of that CSF. Additionally, due to the seriousness of this condition, the patient should be started on empiric IV acyclovir, even before you know for sure that it's HSV encephalitis. And that concludes this section.